It's like a constant war, and you wanna settle that score, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out in the dark, into the light. It's not over, hope is rising. Never give in, never give up. It's not over, yeah, whoa. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winter leaving. It's redemption season. Long live the young and high. Cheers to a brand new start. We're revived and breathing to live a life of freedom.
So, do you want me to start again? Okay, we apologize for the inconvenience right now. So, to ask this again, welcome to another session from the Young Epilepsy Section webinars. Today, we have the pleasure to introduce Professor Eugen Trinka. He's a professor and a chair of the Department of Neurology of the Christian Doppler Clinic at Paracelsus Medical University in Salzburg, Austria. And he is also the chair of the ILAE Europe with more than 400 scientific publications and special interest in status epilepticus, drug trials, and neurophysiology research. Today's learning objectives are appropriately diagnose all types of convulsive status epilepticus, appropriately diagnose all types of non-convulsive status epilepticus, and classify seizures according to the ILAE classification. Thank you, Professor Trinka, for joining us today.
Dear Emil, thank you very much for your kind introduction. Ladies and gentlemen, dear colleagues, welcome here wherever you are. I'm sitting in my comfortable home office. It's rather cold outside. Snow has arrived in Salzburg, but fortunately only on the mountains. But let's get started. So today's talk is about classification, and I put also some principles in management to the talk. These are my disclosures. Some key facts. Status epilepticus is one of the most frequent neurological emergencies, and everyone has to know how to deal with that. 4.5 million each year suffer from status worldwide. The incidence with the new definition of status in adults is 36.1 per 100,000 per year, but with a steep increase in the elderly, and I'll come later to that. The refractory and super refractory cases, they are the biggest problem. They are in fact rare overall. 7.2 per 100,000 refractory, and super refractory is 1 every 100,000 a year. But they make true problems. Mortality rate is high, up to 38%, with no decrease over time. So we still have to improve our treatment. But only less than half have pre-existing epilepsy, and that's a key point. We all have to deal with that, irrespective what the cause is. Less than half have epilepsy. Low anti-epileptic drug levels are one of the major causes, and convincingly 50% are acute symptomatic, so we have to go for the underlying cause. The big five are cerebrovascular traumatic brain injury, infections, and then toxic and metabolic. There's a clear consensus that status epilepticus is a special condition and not just longer seizures, so it's a different thing than what has been thought previously. So today, and these are the objectives, there are some advances in definition, classification, and also in epidemiology. There's a better understanding in pathophysiology with identification of rare causes and the principles of management. Some new treatment principles. The faster you are, the better the patient is off. And there are, of course, some approaches which are new and important to the refractory and super refractory. So coming to the classification, the gentleman on the right upper corner is Henri Gastaut. Status epilepticus is known since ancient times, and the term goes back to Calmet and his doctoral thesis in the left upper corner, 1824, État de mal, and the English translation Latinized is status epilepticus. Gastaut thought that the types of status, they mirrored basically the seizure classification. Every seizure can be prolonged. And he said that the seizure that persists for a sufficient length of time or is frequently enough that recovery does not occur refers to status. Well, as a practical person, that doesn't tell you when to start, what is the true time frame, and so forth. So these were the weaknesses. And the non-convulsive status was not truly defined. Drislane made a very good definition, which you see here in blue. It's an enduring epileptic condition with reduced or altered consciousness, behavioral and vegetative abnormalities, or merely subjective symptoms without major convulsive movements. And I think that's one of the key points. And we said now the time frame to 10 minutes. So the definition of status epilepticus has been revised or put forward by the classification task force with two operational dimensions, T1 and T2, and one conceptual definition, which is as follows. It's a condition resulting either from the failure of the mechanisms responsible for seizure termination or from the initiation of mechanisms which lead to abnormally prolonged seizures after a certain time point T1. It is a condition which can have long-term consequences after a certain time point T2, including neuronal death, neuronal injury, and alteration of neuronal networks depending on the type and duration of the seizure. So why is it so important, T1, T2? T1 tells you when to start treatment. T2 is when you can expect long-term consequences, which you want to avoid. And there's a lot of changes going on. Continuous seizure activity has a high metabolic demand for the brain. There's an increase in glucose consumption with hyperperfusion, disruption of the blood-brain barrier leading to vasogenic edema, which you can visualize in the MRI. Then there is, of course, a shift to the anaerobic metabolism. If metabolic demand exceeds the hyperperfusion, you will not have enough substrate in order to cope with that. There's lactate accumulation, failure of sodium, potassium ATPase pump, water influx, sodium influx, cytotoxic edema, which you can also see in the MRI. And if status is stopped, there's a reversion of the neuronal damages. It can regenerate, but if status is not stopped at this point, there's irreversible neuronal damage and long-term consequences. Atrophy is one of that, but there are also structural and focal pathologies following status. We must not forget the systemic changes which have been in the forefront in the previous generations, in the previous years. There's excessive muscle contraction, metabolic acidosis, lactate accumulation, hyperthermia, electrolyte disturbance, rhabdomyolysis, hypoventilation, respiratory acidosis, hypoxia. We have a catecholinergic storm causing hypertension, acute cardiac failure, for example, Takotsubo, cardiopathy, arrhythmia, capillary leak, and multi-organ failure. This is why people die in status. So looking at the framework again in the different major types of status, generalized tonic-clonic status, T1 at 5 minutes, T2 at 30 minutes. And the other types are the non-convulsive, where there's an important distinction according to the level of consciousness. NCSE proper, and these are the, for example, idiopathic generalized epilepsies or absent status. And the other one is the one without coma and the one with coma, sorry. Focal status with impairment of consciousness, we set the T1 at 10 minutes and absent status same time, but we don't have good evidence. We don't even have evidence that a prolonged absent status causes brain damage. We have to look for that. But we definitely know that around 1 hour in focal status, we see the first signs of brain damage. But what is important is the comatose non-convulsive status epilepticus, which comes out from the generalized tonic-clonic status epilepticus, which is the most urgent and most dangerous forms we have. I already mentioned the steep increase of the incidence in the elderly population. It goes up to around 80, and there's a predilection of women, 89.6 per 100,000 per year in women older than 60 years. And the detection rate also changed in the past years. So in the left lower corner, you see green, the non-convulsive status epilepticus, and suddenly after 2013, we diagnosed almost twice as much non-convulsive forms. And the reason for that are probably the EEG criteria. So when we talk about refractory and super-refractory, there are two studies, one from Finland, Retta Kalvilainen's group, and one from our group, with around the same incidence rates between 1 and 7 per 100,000 per year for the refractory and super-refractory cases. A little bit lower is the incidence in children, 17.6 per 100,000. But what is important is there is a peak incidence in the first year. And this is the subgroup which accounts almost for half of all cases of super-refractory status epilepticus. So in children, lower incidence, most of them occur in the first year, and the half of the super-refractory are in the early childhood. When we come to COVID, we looked at the COVID pandemic where the status epilepticus admissions went down. And what you see here, 18, 19, and 20, we almost had the same admissions of status epilepticus from total admissions, admission from the Salzburg catchment area in the middle gray, and Salzburg city only, which reveals the population-based study. So we had exactly the same numbers. Why is that so? I think it depends on our health organization and the way how we went out and informed the people. But I was very happy when we received this, and I hope it's now under revision in epilepsy. So coming to the classification, 4 axes, semiology, etiology, EEG, and age. But the key point is the clinical semiological classification, where you divide the ones with prominent motor symptoms and oppose them to the one without prominent motor symptoms. So on the left side, of course, there's the convulsive status epilepticus, can be focal evolving to bilateral convulsive, or generalized convulsive, can be myoclonic with and without coma, or focal motor. Tonic and hyperkinetic are rare forms of status. And the ones without prominent motor symptom, the non-convulsive status epilepticus, it's important to distinguish according to the level of consciousness with coma or sopor or stupor and without coma, because they have a different prognosis, as it is the case in typical absent status, atypical absent status, and so forth. And there's one group which you don't know, whether focal or generalized. It's autonomic status epilepticus, which we find in certain epilepsy syndromes. So you may say that this is academic gymnastics to divide so many subtypes, but when you look at the case fatality rates, here abbreviated with CF, you have different rates. The status without the non-convulsive status in somnolence, stupor, or coma, they have the highest case fatality rates, as opposed to the ones where you have prominent motor symptoms with quite a good prognosis. But once they progress to somnolence, stupor, or coma, case fatality rate increases. So the important message is that the outcome of status is associated with its semiology. And the worst outcome is in non-convulsive with impaired consciousness. The dynamic of convulsive to comatose is a poor prognostic sign. And the good outcome is in those patients without impairment of consciousness, plus minus cognitive symptoms. They probably have a very, very low case fatality. EEG is especially important when the patient is in coma. Otherwise, you cannot say whether he or she is in status. And the Salzburg criteria, they are based on a consensus conference, which we had here in Salzburg at the London Innsbruck Colloquium, are quite easy to apply, easy to understand. You need a clinical suspicion, and that's one of the most common misinterpretations. It's not an EEG diagnosis, you need clinical suspicion. Without that, it doesn't make sense to apply that. And these are the key features: transition from premorbid to current illness within minutes or hours, patient with no improvement except waxing and waning, no information from imaging or laboratory, which is sufficient to explain the EEG pattern, for example, acute poisoning or metabolic encephalopathy or brainstem hemorrhage. So then you look at the frequency of the epileptiform discharges. If they are faster than 2.5, you have non-convulsive status. If they are lower than 2.5 cycles per second, you need additional criteria, such as the typical spatiotemporal evolution, subtle ictal clinical signs, or an anti-epileptic drug response when you give intravenous drug challenge during the EEG, and you see that it improves. But you can also have rhythmic discharges faster than 0.5 cycles per second. When you have only rhythmic discharges without epileptiform potentials, you need always one of those additional criteria. If you don't have that, you are almost certain that it's not status epilepticus. Sensitivity is high, 97%. Diagnostic accuracy, more than 90%. Kappa value is very good with 87%. And these are the typical EEGs which you have. They don't fulfill the criteria at the moment, but they are fluctuating, going down to 0.5 hertz and increasing to 2.4, 2.5 hertz, here a little bit faster. That's a fluctuation. And then you need to make the challenge here in this patient with intravenous drug or look at subtle ictal clinical signs. So why 2.5 hertz? That came out from expert opinion, eminence-based, but the evidence followed later. Here is one study from Aaron Struck and Andy Cole's group, where they had continuous EEG monitoring, and they went to the PET, and they investigated the hypermetabolism, which is active in the seizure focus of the status. And the metabolism was compared to the Pons metabolism. And it was when you had an LPD, lateralized periodic discharge, it was increased by a median of 100% at 1 hertz. And 0.5 was the baseline. 0.5 to 100% increase. And frequencies above increased by a median of 300%. There's a linear correlation between the frequency and the metabolic demand as evidenced by glucose PET. So there's a post hoc confirmation that the arbitrary range which we had at 2.5 hertz, you can be very sure that this is clinically relevant and this may cause brain damage if you don't do anything. You have to search for the etiology. It's a known etiology. It's symptomatic, can be acute, remote, progressive, such as Lafora disease or glioblastoma, or it can occur in defined electroclinical syndromes. If you don't find a cause, it's unknown or cryptogenic, and you know if it occurs de novo, you call it NORSE. And that's one thing which is important, because here we have a collection of super refractory cases, more than 700, and we looked for the etiology. This was a global survey, a global audit. 26% did not have an etiology identified. So this is why it's justified to take this as a clinical presentation, new onset refractory status epilepticus in a patient without active epilepsy or other pre-existing relevant neurological disorders, without a clear acute or structural toxic or metabolic cause, which should be identified in 72 hours here based on our consensus definition. But I would go for the big five. You should identify within the first hours of treatment. Otherwise, you miss something. New onset NORSE is important for several reasons. First of all, it is associated with a poor outcome. In this series, 62% had a poor outcome, 22% died, and you have to search for rare causes. Half of them could be identified, 19% autoimmune, 18% paraneoplastic encephalitis, and 8% infection related. So it's worthwhile to identify the underlying cause and treat it appropriately. How do you treat it? Not only with anti-epileptic drugs, but there's a whole range of immune drugs which you give, and I come later to that. So strategy number one is identify and treat the cause of status epilepticus. Strategy number two is to treat early, T1, and you have to start treatment because you want to avoid what happens at T2, long-term consequences and brain damage. So there's a cascade of events which was beautifully summarized here by Bethemans and Daniel Lowenstein in Lancet Neurology 5 years ago, You have phosphorylation, ion channel opening, neurotransmitter release, where GABAergic drugs are on the forefront and they work quite well. Then you have receptor trafficking, increase in excitatory NMDA receptors, decrease in the inhibitory GABA receptors, neuropeptide expression, and then you have genetic and epigenetic changes when the status goes on and on. So it makes sense to use anti-glutamatergic drugs later because you have a GABAergic failure where the GABAergic drugs don't work. But what we also should consider is to treat early with 2 anti-epileptic drugs with different modes of action. There's no evidence for that, but I think it's a worthwhile approach. But you have to bear in mind that these cascade of events is for convulsive status and comatose non-convulsive. They may be completely different in the epilepsy syndromes, absent status, epilepsia partialis continua, and so forth. So one model doesn't fit for all, but we should keep this in mind for the most dangerous convulsive forms. And then, of course, you have to start treatment after T1 in a staged approach tailored to the pathophysiological changes which have been outlined before. There's a close time frame, and I always use this time frame. Stage 1 is 5 to 10 minutes. You have 10 to 30 minutes. That's the time when you should control the status. And if you don't control by the hour 1, 60 minutes, it's time to consider intensive care, treatment, and anesthetics. And by more than 24 hours, I think we are in deep trouble, and we must identify the cause. So it's clear benzodiazepines in the first run, lorazepam, diazepam, clonazepam, followed by anti-epileptic drugs. Virtually every treatment guideline follows these principles. And when you ask about the evidence, well, there is now some evidence that this is truly the most effective treatment. But what happens in reality? So if we look at the randomized controlled trials, about 60% of status are controlled with whatever benzodiazepines you give. This is from a series from Germany, Austria, and Switzerland, where we collected 1,050 patients, real life setting. 86% used benzodiazepines in the first run, and the median latency between onset and first treatment was half an hour, right? It was not 5 minutes, it was half an hour. There you are already in T2 in many cases. And the bolus doses were below the guidelines in 76 and 78% of patients. So more than 3/4 of patients didn't receive the appropriate dose. And this leads to, of course, not a good result. So if you use levetiracetam as first treatment, on the left graph, you see how often status was controlled after 1 hour. It's almost less than 10% when you use levetiracetam. When you use benzodiazepines, it's controlled in about 20 to 40%, but not in 60 to 70% as it is in randomized controlled trials. And I think because it's most often underdosed, and this is one of the key problems, we have to hit early and hit hard in those patients which present with convulsive forms of status. Once the benzodiazepines fail, you go to the anti-epileptic drugs, phenytoin, levetiracetam, valproic acid, phenobarbital, and lacosamide, where, you know, all of these drugs, they have advantages and disadvantages, which you must know when you apply them. This is not very difficult to learn, and I think the key facts are presented here, the dose which you apply, and the most often side effects or disadvantages. So which of those drugs is the best one? There's one study which was planned, also coming out from London Innsbruck colloquial status, comparing levetiracetam, valproic acid, and phosphonatoin, called the ESET trial. And everyone it's a marvelous design. It's a masterpiece of drug design with double-blind, randomized, and adaptive trial design. So what is the outcome? No difference between those 3 drugs published in New England Journal of Medicine, about 50% chance of controlling status. So 60% with the first line, Again, of those who do not respond, another 50%. So overall, we have 80% success rate with the first two steps, 80%. Difference in side effects? No, although there was slightly more life-threatening hypotension within 1 hour with phosphenitoin, but the patients are monitored and you can cope with that. There are two other trials coming out last year, Lancet, levetiracetam compared to phenytoin, not phosphonate, phenytoin in children, the concept trial. No difference between those two drugs. Levetiracetam is not superior. And another trial in the UK, the Eclipse trial, same comparison, same paper, same journal, Lancet, 2019, same result. Levetiracetam was not significantly superior. Well, the absence of superiority doesn't mean the proof of equivalence, which is an important message, but taken overall together, these drugs, there's no big difference. So what we have here is, of course, that we have two other drugs, and soon we have a third intravenous drug, which is not covered by these trials. Lacosamide, for example. Adam Strelczyk collected these cases, and many of them come from our center. 522 episodes, 57% success rate, different types, different stages, but overall, it's worthwhile to include that in a larger trial. One method to compare results, smaller trials, bigger trials, is doing a network meta-analysis with indirect comparisons. Together with Francesco Brigo, Simona Lattanzi, and our Italian friends, we compared these trials, 5 randomized controlled trials, valproic acid, phenytoin, diazepam, phenobarbital, lacosamide, and levetiracetam in a network meta-analysis giving effect sizes or estimates of effect sizes. Here you see the comparisons. The strength is depicted according to the number of comparisons or number of patients within these comparisons. And here you see the overall plot between the comparisons, whether it favors the first intervention or the second intervention. But what is important here is those in pinkish, you see that they stand out because all of them involve phenobarbital, and all of them are better than the comparator. So what we can say is that phenobarbital was superior to phenytoin, valproic acid, diazepam, levetiracetam, and lacosamide with respect to state to cessation, but valproic acid and lacosamide had the greatest likelihood ranking best for safety outcomes. So if we use phenobarbital, you probably have a high chance of controlled status, but at the price of adverse effects. Unfortunately, phenobarbital was not included in the randomized controlled trial ESET, Eclipse, or the concept trial. And I think it would be worthwhile to look for these old but good drugs. Brivaracetam is another one. Here again, a meta-analysis or collect systematic review, 37 patients, success rate varied. The reason why it's interesting is because it enters the brain faster than levetiracetam. This is from an animal study, but there's also human data that there is a big advantage with brivaracetam for entering the brain. Perampanel, I think that's important because it's anti-glutamatergic. So from a rational point of view, it should be used in the later stages of status epilepticus, and it will come out soon as an intravenous solution. It took years and years in order to convince the company that this has a high potential as an intravenous drug, and now they're doing it, and they have the bioequivalent study now filed. So we used it in several patients overall, more than 30 patients now, in different approaches. Starting with low doses doesn't make sense. This drug has a half-life of almost 100 hours in many patients. It increases with enzyme induction. So you need to have a high dose at the beginning in order to achieve the drug levels which you need to control. So we start now regularly with 32 milligram, and then we go down to 24 and 12, 14, 16, according to the serum level. Unfavorable outcome was there in 13 patients and good recovery in 9 patients. And that was more common in the high dose treatment group as compared to the standard group. So that was the first hint that we should go for high doses per nasogastric tube. And we do this now, waiting for the intravenous solution. So the stage treatment protocol is quite straightforward. Benzodiazepines in the first range, anti-epileptic drugs in the second range. Whatever comes as intravenous anti-epileptic drug should line up here because the benzos are so good in the first range. And then if that doesn't work, you have to proceed to anesthesia. But there are some practice points which I think are important. Don't delay treatment by switching in stage 2 between the drugs. There's a pharmacokinetic interaction which you have to know between valproic acid and phenobarbital on the protein binding, and topiramate. After failure of phenytoin, go to stage 3 treatments. And after failure of levetiracetam, brivaracetam, valproic acid, or lacosamide, you still have time for phenytoin because you need, for those drugs, you only need 5 minutes to get in and you see the result. But all of you are doctors and we have to make decisions under uncertainty. We weigh risks and we weigh benefits for the treatment. And what is important is to consider the risk-benefit ratio of stage 3 treatment in patients with a good prognosis, in idiopathic generalized epilepsy with absence status, for example. I read several case reports where they went to anesthesia, but they have in fact a good prognosis. And older elderly with comatose non-convulsive with a very poor prognosis and a very high chance to die. Identify the cause, think twice what you do when you put a person at that risk with that comorbidity in a respirator. Having said that, on the other hand, if you have a super refractory case in a patient with NORSE, never give up. They have a chance to survive, and they have a chance to survive also with good outcomes, even if there are weeks in status epilepticus. So when it comes to the third line, general anesthesia, I would say that ketamine should be one of the first drugs used, which you see here. So I move, in our treatment algorithms, we move ketamine up. Everyone gets magnesium bolus and high levels, and then we consider immunotherapy even without knowing whether it's immunological course. And that's also very much in line with some treatment protocols which have been published for NORSE and FIRES, new onset superrefractory status. You have immune therapies quite early in the course. Still, we believe that this is better, but there is no proof that it is truly better. So which treatments do we give? In about 50 to 60% of all cases, immunotherapies were applied in this NORSE. Plasma exchange is one of them. This is in our neuro-intensive care, where we do this quite often. It's the only center doing plasma exchange or membrane plasma separation treatment with a specific team. Most often, and this is from a recent series we published, it's limbic encephalitis, NMDA receptor encephalitis, or brainstem encephalitis, where we use this type of treatment. It's always together with other immunomodulating treatments, and the clinical response is good in at least half of these patients. You have to get rid of the pathogenic autoantibodies. The problem is when you don't identify an autoantibody, a known autoantibody, there's still an immune response, and you have to consider immune treatment for the consequences of the seizure on the immune response, which is a consequence. Here, we talk about the cause, and it's clearly that the febrile infection-related epilepsy syndrome is immune mediated, because you see a lot of immune derangement. In many of these patients, you see a cytokine storm. This led to the assumption from this group that anakinra, which is an interleukin-1 receptor antagonist, is helpful. That's a single case report published 4 years ago, now in Annals of Neurology, which convincingly showed that anakinra had an effect in these patients. There were, of course, other factors which led to this treatment consideration. We now use this also with, let's say, intermediate success, but it's well tolerated, and you have to look at the short half-life of this drug. So if you want to apply this, you need to have it in a much higher dose, which you use in rheumatology, for example. And another drug which we now use regularly is tocilizumab for nausea. This series from Yin-Sung Yoon from Korea is very convincing. When you look at these cases, they all had rituximab, they had nausea, classical, and they were not going well on rituximab, which is a CD20 drug, bringing down the CD20 lymphocytes. 5 had rituximab, no response, and treatment with tocilizumab, which is an interleukin-6 inhibitor, a receptor inhibitor, terminated after 1 or 2 doses, 6 patients of the 7, with a median interval of 3 days. Well, so far we cannot confirm these extremely impressive results. So we had complications, which you see here, severe infection, sepsis, pneumonia, which can complicate the treatment. But I think it's something which you must consider giving these patients. You can also monitor the effect, because when you block the interleukin-6 receptor, interleukin-6 goes down, but the cascade doesn't proceed. There are other drugs, and I come to an end here. There are other drugs which are quite interesting. One is neurosteroids here, ganaxolone. Ganaxolone just finished a phase 2 trial successfully, and now they are going into a phase 3 trial in drug-resistant status epilepticus. And I think it will be very important to have another drug which can be used here based on randomized controlled trials. What is also interesting is neurostimulation. There are several types of neurostimulation. Deep brain stimulation, there are overall 4 cases with deep brain stimulation, which also published in Annals of Neurology by Lehtimäki. They have quite a good response, and that's astonishing. I wouldn't expect that. But what you see is, of course, that the people publish it when you have a good response. So there's an intrinsic publication bias within all these reports. 43 patients with vagal nerve stimulation have reported a cessation of status in 67%. What I think is important here is that whenever such a thing is reported, we have to follow that and see whether it's also true in a standardized setting, in a prospective protocol. And I think the risk-benefit ratio is excellent, because you don't poison the patient once it's refractory. So coming to a conclusion, status epilepticus is one of the most common neurological emergencies. The new definition which we put forward with T2 guides earlier appropriate treatment, and it provides a framework for treatment escalation when you come to T2, depending on the different types of status. But what we want to do is we want to prevent, of course, brain damage. The classification is based on semiology, etiology, and EEG. And there's a clear dichotomy between the convulsive and the non-convulsive status epilepticus, with clear prognostic implications depending on the impairment of consciousness. So we have 2 taxonomic criteria: motor activity and level of consciousness. There's evidence that benzodiazepines are best in the early stages with control of around 60% of all patients in status epilepticus. Later, we have, I would say, equivalence of valproic acid, levetiracetam, and phosphonatoin. We can choose based on comorbidity, etiology, as well as guidelines and doctors' habits. So I would avoid phenytoin in every patient with a cardiac problem. I would avoid, of course, patients, valproic acid in patients with a known severe liver disease or mitochondrial disorder, or at least you should use it with extreme caution and only once you root out, for example, POL gamma mutations. Lacosamide and brivaracetam were not included, so these are interesting drugs to follow. There's a drug in the US, which I did not talk about. It's ketamine add-on trial in the US and ganaxolone in the US and European Union for this refractory cases. Very much looking forward to the results. And antiglutamatergic drugs can be produced in different formulations, and perampanel, another AMPA receptor blocker, is now under development. They're doing the bioequivalence studies for the intravenous solution, and there are several other application forms of ketamine under investigation. So there is a lot of things to come, including data registries for immunosuppression in super-refractory status epilepticus and also neurostimulation and ketogenic diet. Hope to see you at this conference, which takes place next year. I don't know where and I don't know when, but we try to keep our date not in April, but in the autumn of the year for bringing you news in status epilepticus. Thank you very much for your attention.
Thank you very much, Dr. Trinka. This was an excellent webinar. So there are some questions from the audience. So the first one is it better to start treatment with benzodiazepines? And if refractory, use another anticonvulsant, or start from the beginning 2 different anticonvulsants at the same time?
Yeah, there is no study looking for that exactly. So there was one study, and I didn't quote it, where levetiracetam was used together with clonazepam in France, and was compared to clonazepam plus placebo. So one arm received clonazepam, standard of care, plus levetiracetam, and the other one clonazepam plus placebo. So you have an indirect comparison whether the treatment combination is better than a benzodiazepine alone in the early cases. So the outcome was astonishing. No difference. They interrupted this trial, and they interrupted it because they couldn't expect a difference. The endpoint was set at 1 hour, and that's too early for the effect of levetiracetam. So your question is very valid. I cannot answer it precisely, but I think it makes sense to treat with benzo plus anti-epileptic drug right at the beginning, although we don't have any evidence, and we should work on that to create evidence.
Okay, thank you. In another question, in a patient with non-convulsive status epilepticus and no clinical response with initial sedatives, how much time do you recommend to wait in the continuous EEG improvement before considering failure and adding a new therapy?
Yeah, that's a good point, because assigning a success to an intervention has some inherent problems, and the most problematic in this case is time. So how long do you wait? And that depends. You cannot give an absolute number, because that depends on the pharmacokinetic characteristics and pharmacodynamic principles of the drug. So if you have levetiracetam, which takes minutes and minutes to enter the brain, you must wait longer. If you have phenytoin, which has a cardiac toxicity, and you have to slow down the infusion rate, maximum speed 150 milligram per minute if you use phosphonatoin, but only 50 milligram per minute if you use phenytoin. So it takes half an hour. So you can only assess the effect half an hour plus. With levetiracetam, I would also say you get it in 5 minutes, but when you need to see the effect, it takes longer depending on the blood-brain barrier. If this is a patient with no disruption of the blood-brain barrier, well, then you may take longer. But if there is a disruption, like in many patients in the intensive care unit with continuous EEG, you may get the result earlier. As a rule of thumb, if there is nothing after 10 minutes, I consider that you should think about another drug and prepare everything. And then you wait another 5 minutes and then you apply the next drug. The only thing where you pause is when you make the decision, ventilation or not. You have to organize, you have to call the colleagues, see whether bed is free and all these logistic things. So although we wish to proceed as quick as we can in those patients who need it, there are logistic challenges, so it always takes a little bit longer than what you read in the usual papers. Most of the time written by doctors, not doing that personally. So that's an important thing. So I would wait at least 10 minutes in phenytoin, longer, but then make the decision to use another drug.
Okay, thank you. So another question is, what are the difference between management of non-convulsive status epilepticus with coma and without coma?
Yeah, the one non-convulsive without coma is, for example, absent status. If you take this absent status, it's most of the time either drug withdrawal, maybe also intentional withdrawal of the drugs when you want to taper down, or application of inappropriate drugs. If you give a patient with childhood absence epilepsy, if you give him phenytoin or carbamazepine, it will worsen. So these cases are generally easy to manage. You remove the drug which causes the status, for example, carbamazepine in JME, and you give valproic acid or benzodiazepines in this drug. So these are patients not in coma. They have a delayed responsiveness, but they are not in coma. And this is what I mean when I say non-convulsive proper or non-convulsive, non-comatose, non-convulsive. Definitions with non is always problematic, but you know that these are the patients which respond. The other ones are comatose, and they have the EEG pattern, and sometimes you see clinically nothing except deep coma. And they have to be treated, of course, rigorously because the brain is under severe fire, and this is what you have to stop. So the non-convulsive proper without coma, don't harm the patient, don't overtreat it. You have to recognize it. It's the what was called by Fukushima was called it's the ictally wounded as compared to the walking wounded and the ictally comatose. So patients with absent status can walk into the clinics, can talk to you a little bit blurry, they lose contact, but they're not in coma. And the other ones are deeply in coma. These ones, you have to concentrate the treatment. The other ones don't harm the patient.
Probably there's the same situation with focal status epilepticus without alteration of consciousness, right?
Yes, it's probably the same consideration, but there's a little bit a different thing. So if this is, of course, a focal status coming from the limbic system, unilateral, you should consider limbic encephalitis. You should consider also hippocampal damage if this is ongoing. So I think this is kind of in between. And what you also have to search for, if you have a focal status going on and on, there is 100% the brain pathology causing that. And if you cannot treat this by with medicine or medically, you should also consider surgery or neurostimulation locally if this is not amenable to surgery. The few cases where epilepsy surgery was done emergent within the phase of status, these had all a clear focal pathology.
Okay, thank you. So another question is, should you have immunoglobulin measure on CSF before starting anakinra or tocilizumab? And what if these tests are not available?
No. So what you have to think about the contraindications with anakinra and tocilizumab are, of course, florid infections. So if you have a patient with a clear infection or sepsis, these are contraindicated, or you should stop giving this in a patient. So we had a patient now where we started with tocilizumab, then we switched to anakinra high dose, and he went into sepsis, which is of course a disaster. So we had to stop the treatment. So what is advisable, because all these drugs, tocilizumab, anakinra, or others are used by oncologists or rheumatologists. So you have to liaise with that in order not to find the appropriate dose. In neurologists, we use higher doses of these drugs because we want to achieve an effect, and we want to achieve an effect also in the brain, which is the target. But according to the side effects, they are more experienced with the side effects, and I would say that it's advisable to do that, but you don't need a pretest searching for all the immunoglobulins or cytokines, whatever, rule out an active florid infection. That's more important.
Okay, so the person who asked that question, he's clarifying that the thing that he wanted to ask is that if you need to measure interleukins instead of immunoglobulin, he wants to know is that if you need to measure interleukins in CSF.
No, you don't have to, but it would be good if you are able to do that, because what you see, again, an example, when you have a patient where you don't see any change in cytokines, it's probably not a relevant factor. So then what sense does it make to apply an interleukin-1 receptor or tocilizumab blocking the interleukin-6 receptor when you don't have that? It doesn't make sense. In these published series, they all had a very nice cytokine profile with all elevated factors. But what do you do when you cannot measure it in a, let's say, low-income country? The patient is having ongoing status. You don't have another explanation. I would think it would be wise to do that even without knowing the actual cytokine levels in the CSF or even in the serum. You see, if we always wait for 100% confirmation and we need to see this in the laboratory, patient is ongoing in status, and you have to make decisions. And as I said earlier, we have to make decisions under uncertainty, and we have to take the responsibility to do that. So it's always weigh the risks and know what you do, because when you do it for your first time, of course, it's better to consult with a person who has more experience with these drugs. But I think you don't need all the tests before starting it.
Okay, thank you. So another question is, taking into account on poor prognosis in elderly patients with refractory non-convulsive status epilepticus, how aggressive must the treatment go?
Yeah. Okay. It's not possible to give a general recommendation. So if you have, I give you just 2 or 3 examples. If you have one person, 79 years old, severe frontotemporal dementia, frailty, multimorbidity, with a guardian, there's almost nothing to gain when this patient it comes to an intensive care unit, is ventilated. Let's assume also a COPD. So then it's probably better to try to get control of the status without ventilation, without anesthesia. On the other hand, you have a 89-year-old person who was climbing on the mountains the last week before the snow came. He's eagerly waiting to go skiing. He's mentally fit, no relevant history previously. Well, then I would say I would go. Yeah, so it depends on the context, on the whole picture which you have, and on the whole information. And how to decide that, I cannot give you a recipe, but you should always go inside the patient and get the information from all the people around him, from the family. How would he or she have decided in this situation? What is the expected or the assessed will of this patient? And that's the will of the patient is our command. This is what we have to do. It's not us that we say, well, it's not worthwhile. No, we have to think, well, even if the hope is low, but the patient's wish is so important, we have to follow that. Age is a very poor marker. Of course, comorbidity increases with age, but also an elderly has the right to live and the right to die in dignity.
Yeah. So another question, I think this is regarding non-convulsive status. So what medication would you recommend for doing the trial to see if there is improvement in EEG and clinically?
So what we do in a patient, well, it also depends on the setting. In many cases, you don't know the dose which was applied outside in the field by the emergency doctors, and you can expect that the dose was always too low. So the first choice is, of course, if you have a low dose of benzodiazepine, you have the EEG, you reload the patient with benzodiazepines, and then you wait. Second is what we do, we give intravenous levetiracetam, 2,000 milligrams or 3,000 milligrams very rapidly in order to achieve a dose. That's what we do. And in patient who already was on levetiracetam, we try to get them, we give another drug, for example, valproic acid or lacosamide, if we think it's a focal pathology. So it's very individualized, or at least we think it's individualized as good as we can, based on the comorbidity, on the previous drugs or previous drugs failure. But what you must not forget is always look for the benzodiazepine, which is the most effective in these early stages. And if it's underdosed, which is the case in 75% in Germany, Austria, and Switzerland, go for that and see the EEG response.
Okay, another question is why there is no difference in treatment for generalized status like absence or juvenile myoclonic epilepsy compared to focal onset status epilepticus?
Well, you see, the framework which I presented is a general framework, and you have to move and tune it according to what you just said. It's a very important topic. So if a patient with juvenile myoclonic epilepsy goes into status, it's either because he or she didn't took the tablets, has inappropriate treatment like phenytoin or carbamazepine, or lamotrigine, for example, which also makes that. So valproic acid intravenous is the drug of choice. So there, I would not start with benzodiazepines, and I would treat it completely different. In focal status epilepticus, as you mentioned it, I would not give valproic acid as a primary choice, because by all knowledge, what we have is that the efficacy in focal pathology with valproic acid is lower than it is in generalized pathology, generalized epilepsies. Absence status, valproic acid, for example. So there is a difference in the management, but when you look at the framework, you still have the same principles. It's 1, 2, 3, what you get. With idiopathic generalized epilepsy, you would probably not need to escalate to stage 3 treatments, but you choose the ones which are active in generalized epilepsies. Valproic acid, levetiracetam, maybe also lacosamide, but definitely not phenytoin. Phenobarbital, that can be chosen here. So there is a difference.
Okay. So in relation to continuous EEG, what will be the role of burst suppression goal in the future versus the total clinic and subclinical seizure control?
My opinion is that we overtreated the patients with phenobarbital in the previous years, mainly because we targeted burst suppression, and we said that the longer the suppression is, the better it is, and sometimes also until the isoelectric EEG. The adverse effects of phenobarbital or thiopental pentobarbital are colossal. So a negative inotropic, it depresses the immune system to a certain extent. It makes sepsis. It can make gastric paresis and duodenal paresis, so it impairs the absorption, and many other problems with phenobarbital. So I think when you use phenobarbital in order to get a burst suppression, for me, I think it's better to control the seizures and not going to the target burst suppression. With other drugs, you don't have the same nice target as with phenobarbital. So overall, I think the goal should be control of seizures and not putting the patient into deep coma, because then probably you harm the patient more with the drugs. I'm in favor now, with all the experience over the years and the data which came out, not to go into burst suppression in these cases as a primary goal.
Okay, thank you. So the other question will be about lateralized periodic discharges. So how should we approach them? If we treat them as an epileptic kind of discharge, how far we should go? Should we use general anesthetics to treat lateralized periodic discharges?
Yeah, again, a good question. So maybe think about what is the disease causing the LPDs, helps you in making the decision. So if you have a cortical dysplasia, making LPDs, the patient is well off. He can talk to you. There's nothing special, but it fulfills the criteria of LPDs in a patient with cortical dysplasia, or watershed infarction in a vascular patient, not impairing his or her everyday life dramatically. So you should be cautious in overtreating these patients. On the other hand, if you have a patient somnolent, stuporous, comatose with LPDs and a lateralized pathology, you should treat that, of course, in order to stop the increased metabolic demand which you have with the LPDs locally. So again, there's not a single answer to that. It depends on the clinical situation and on the etiology. If this is a patient in coma with a structural pathology, go for the treatment, and then you have to treat really to a sufficient level. In the other cases, you have all the time in the world, and you can see whether this or the other anti-epileptic drug work. The patient is not impaired by the LPDs only.
Okay, so we have two more questions. So how long we should maintain burst suppression before tapering IV anesthetics?
Well, let's say if you insist on burst suppression, you should go there for around 48 hours. These are the recommendations, 24 to 48 hours. There's one study with a multifactorial analysis, which comes to the conclusion that 36 hours is the best. So it's between 24 and 48 hours. And those where you apply higher doses early in the course and go rapid out had a better outcome. Well, I don't know whether this is a proof that this is really the right approach, but that's a hint. So let's say 36 hours, then you go out. Again, think about whether burst suppression is too much or whether it's appropriate, because when you control all the seizures which you have in a patient, I think that would be enough to say, well, the drug works, right? So you don't need necessarily always have a burst suppression.
Okay, so the last question will be, is there evidence that supports the use of phenobarbital in infants of 6 months old or less?
No. Childhood, I'm an adult neurologist, but you know, a lot of my friends are pediatricians and childhood doctors. There is almost no evidence what to use in the first year of life. Phenobarbital is, according to many experts in the field, still a good option for these patients, although there are reports that they impair neuronal development, that they have an effect on the brain development, which is very difficult to detangle from the cause of the status and the brain damage itself. So you don't know whether it's truly phenobarbital, but in an experimental setting, phenobarbital can have a bad impact on the brain. Many of the pediatricians now use levetiracetam. Some of them say with intermediate success, and they have to move to other causes. But again, I have to defer this to the specialists. Unfortunately, very low evidence, and think about the mothers and the fathers, whether they would agree in a randomized controlled trial in the first year of life, because everyone says, yes, I want to have the best drugs, but don't try it with my child. So it's difficult to make this in this setting.
Okay, I think that's it. Thank you very much, Professor Trinka, for such a great webinar. So we hope to see you soon in the next webinar.
Sure. I hope to see you soon live again. It's always much better than in the webinar. But thank you very much for guiding this so excellent. And I have to say thank you for organizing an educational thing coming out from the young epilepsy section, which is an excellent idea. Thank you.
Thank you very much. So see you next weekend.
Bye-bye. Bye-bye.
Bye.